ट्यूब दिखा रहा 7.5 है ना?
यस सर।
कफ चेक कर ले।
कब देख लिया सर?
15 दे दिया, ठीक है।
सलाइन स्ट्रेच करते हैं।
ठीक है, हाथ में डालो।
इसमें ना दिस इज अ डिफिकल्ट एनाटमी, राइट? Why it is difficult anatomy? Because the patient is obese, having a short neck. Anatomical landmarks, they are not very clear. You have to identify the thyroid cartilage, right? So this one is most likely a thyroid cartilage. This is your thyroid gland, right, which is underlying the cricoid cartilage. So you have congestion for the anatomical structures, which means all the anatomical structures, they are overly packed up in a small space. So you will not have a freedom to move around. So they are generally difficult. But first, what we do, let's see. This is your sternal notch, approximately 1.5 to 2 inches proximal to the sternal notch. Should be a cricoid cartilage. I can feel also. So here I will give Silocaine with area.
वो साइड को भी कराया ना। हाँ वो कभी तो दोनों रखना। Ratio 140/82.
बेटा propofol I need.
दे दिया मैंने सर।
कितना? Just note करके रखना. I need saline. With the tube cuff you will have to deflate.
एक डिस्को दे दीजिए प्लीज।
I'm making a skin incision. So now there will be, you have to do a blunt dissection, right? What is the heart rate beating?
Heart rate 132, heart rate 140/82. SpO2 100.
BP is 144/85.
Very good. BC type. So I will withdraw the tube slightly. Just keep the cuff like this. Not able to go inside, it means the tube is overlying this one. We will see just in case we can negotiate. So this is actually a tricky thing, not so easy, because negotiation requires a lot of proprioception. Give me jelly please.
Blood pressure 166/99.
Give 3 ml of
3 ml propofol. Fine. This side. Plus
the sheath, the needle, as well as the initial guide wire mount, everything is out. We just have a guide wire inside, huh? So now you have to do, what is the next step?
dilatation.
Yes. So the skin and the subcutaneous tissue and the tracheal stem needs initial dilatation, huh? So again you have to stabilize.
71/93.
एक बार वापस
So now it is engaged. Prashant, this is known as what? This is single stage dilator, right? So this has to get engaged with both the skin, subcutaneous tissue, as well as the treacle stem. So now it is inside, huh? So now I'm going to dilate. Now you can see the gush of air as well. So dilate it.
How much space? Approximately 1 centimeter.
Approximately maybe 1.5 to 2, depending upon the size of the tube which you want to insert. Where is the tube?
7.5
Blood pressure 153/79.
Okay, good. So in the yeah, very good. Actually, with a short neck, the problem is that your patient is having such a small space to operate. That's why it becomes tricky. So catheter mount new. Better disconnect this catheter mount. Inflate this tube. Inflate this one. No problem. Inflate, inflate.
Sorry.
So what you have to check, if the tube is inside, there has to be visible chest rise. So you can see visible chest rise.
Yes.
You have to see the return of expiratory time. This is you are giving 400 and the return is 408. So which means it can only happen if it is there in the right space. The patient is having a stable heart rate, blood pressure, saturation. So we have that. So this is tracheostomy done easily.
Then
Now we will have to take a suture. So when we were discussing, these are all difficult cases because normally PCT is recommended when the anatomical landmarks are very clear. If the anatomical landmarks are not clear, then you should ideally not be doing it. Why? Because you don't know which plane you are going into. Cut it, please.
Can there be a risk of injury to the thyroid gland?
Yeah, of course. Last case, when you remember, the one which was the lady, Anuradha, she has gone into the thyroid gland. She was having so much of vascular thyroid structure. Yeah.
Yes.
In fact, there was a possibility we may have hit onto this one, but she bled mainly because of the other reasons, so not because of per se the injury, because she already had some supraclotic injury beforehand. So rather than saying because arterial bleed, it's difficult to stop unless and until you either ligate them or you cauterize them.
Cauterization is not an
Cut.
option.
Cauterization you can do, but in PCT we don't do cauterization and all. PCT is a place where most of the things there. That's why I'm saying these are relative contraindications. Where you feel that the patient is having a possibility of bleed, there you should not use percutaneous. You should use more surgical one. Everything has a learning curve. If you keep on doing it, then